Good afternoon, all. On behalf of Pediatrics Keynote 3, I welcome you all for this CCR. So today we will discussing the one case where there always the dilemma TB or no TB. So without wasting time, I invite Dr. Mudit to present the case. So he will present the case along with our colleagues from the pathology, radiodiagnosis and adult technology, and then Dr. Sheetal will discuss the discussion part. Dr. Mudit.
Good morning, good afternoon, everyone. So we'll be presenting this case on to be or not to be. That is the question that we'll be addressing with this case. So the index case is of Miss A, a 12-year-old girl, a resident of Allahabad in UP. The informant for the history was mother and the history was reliable. She presented to us in September 2019 with the following chief complaints: fever for 2.5 months, pain abdomen for 10 days at the onset of symptoms, breathlessness for 2 months, one episode of left focal seizure which occurred 1 month back, and cough for 1 week. So onset of symptoms was in July 2019 and she presented to us in September. So in July, the patient initially presented with a history of fever which was high grade, daily spikes of 103 to 104 degree Fahrenheit, although there were no chills, rigors or rash. Along with the fever, during the first 10 days of onset of symptoms, she had an abdominal pain which was dull aching periumbilical, mild in intensity, no other gastrointestinal complaints. She also developed complaints of breathlessness 10 days into her illness. The breathlessness was rapidly progressive, and within 20 days it progressed from MRC grade 1 to grade 4, and this breathlessness persisted throughout her presentation. 1 month into the illness, she had an episode of left focal seizure which lasted for 1 minute. It was an isolated episode. And for the last 1 week before presentation to AIIMS, she was complaining of a dry non-spasmodic cough. There was also a concomitant history of weight loss of about 10 kgs in the last 2 months. No history of loss of appetite or contact with tuberculosis or no hemopsis. No other rheumatological complaint like joint pain, swelling or rash, and no other CNS complaint in the form of altered sensorium or any focal deficits. So with these complaints, before presentation, she had already been admitted thrice at various hospitals. The first admission, she received IV antibiotics in view of the respiratory distress. She required non-invasive ventilation for 3 days and was eventually discharged on home oxygen. Levetiracetam was started for in view of the focal seizure, and based on the radiological findings, she was started on first-line anti-tubercular therapy. Although no microbiological evidence was present, 1-2 gastric aspirate for AB were negative. She was admitted again in view of worsening respiratory distress, and on evaluation was found to have a right pneumothorax, following which an ICT tube was inserted. However, there was no significant improvement in the fever or in the respiratory distress. She was admitted in a government hospital elsewhere a third time, where ATT was stopped after being given for a total duration of 1 month. IV antibiotics were given, the oxygen was tapered off, and the ICT was removed. However, her symptoms persisted. The past history was non-contributory, birth history also was non-contributory. There was no history of tuberculosis in the family, and there was only a history of asthma in the paternal aunt. She was immunized till 5 years, developmentally normal, and there was no history of exposure to any birds, pets, animal dander, or any factory or damp walls that were present in the vicinity. So at admission on examination, the vitals revealed a pulse rate of 115, and she was tachypneic with a respiratory rate of 38 and significant chest contractions present. Other vitals were within normal limits. General physical examination did not reveal any pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema, and the rest of the head-to-toe examination was also normal. Anthropometry wise, the patient did not have any features of failure to thrive. On examining the respiratory system on inspection, trachea was central, chest was symmetrical, although there were reduced movements on the right side, and a sutured wound was present in the right side. On palpation, the inspection findings were confirmed and vocal fremitus was equal. Percussion revealed a resonant note in all quadrants, and on auscultation, while she had bilateral vesicular breath sounds with equal air entry, there was presence of bilateral inspiratory crepitations. The cardiovascular examination, the parabdomen examination, and the central nervous system examination were all within normal limits. There was no organomegaly present, there were no focal deficits present, or no meningeal signs that were present. So to summarize, this was a case of a premorbidly normal 12-year-old girl who had been symptomatic for 2.5 months with fever, breathlessness, abdominal pain, cough, 1 episode of focal seizure, and unintended weight loss. There was no history of TB contact. Her course had been complicated with a pneumothorax, and she was having persistent fever and respiratory distress. She had previously been admitted at 3 facilities, received first-line anti-tubercular therapy for 1 month and several courses of IV antibiotics without any improvement. And examination revealed tachypnea, bilateral crepitations in the chest, and no organomegaly. So the possibilities that we were kept at this time after considering the history and examination were of disseminated tuberculosis, multisystem connective tissue disorders like SLE given the age and sex of the child, and presence of both respiratory system and CNS involvement, vasculitis such as granulomatosis with polyangiitis and sarcoidosis. Coming on to the investigation revealed that hemoglobin had fallen significantly from a baseline of 12.3 to 9.5 when she presented. She did not have any leukocytosis or leukopenia. The TLC were within normal limits and had neutrophilic predominance. She did not have any thrombocytopenia. Her renal function and liver function, although she had some transaminitis at the beginning, they had normalized by the time she had presented. Further, I invite Dr. Rashmi to discuss the radiology.
So I'll be discussing about the radiological aspect of this patient. So here we have serial imaging done for this patient. This is the initial chest radiograph, which appears to be grossly normal. And in the subsequent CT scan, HRCT scan, we can see that there is evidence of multifocal tiny GGO nodules seen distributed diffusely in bilateral lung fields. And few nodular consolidation are seen in the peribronchovascular region, few of them showing air bronchogram within. However, mediastinum appeared to be normal, no evidence of any lymphadenopathy. And in the subsequent scan, which was done in the month of August, we can see that there is progression of these nodular opacities, GGO as well as solid nodular opacities, and there is development of these few cystic changes, predominantly seen on the left side. And we can see that there is development of pneumothorax on the right side, which showed partial regression on the next scan with ICD in situ, and we can also see reticular nodular opacity seen diffusely in the left lung fields. And in the subsequent scan, we can see that there is resolution of pneumothorax. However, the reticular nodular opacity appears to be progressed. And these are the subsequent contrast enhanced scans for the patient. So we can see that there is coalescence of these nodular opacity into patchy areas of consolidation showing air bronchogram, and there is progression of these cystic lesions as well, and there is development of bilateral pneumothorax with ICD in situ. So radiological possibilities include the cystic lung disease like LCH or vasculitic disease like granulomatosis with polyangiitis, sarcoidosis, and lastly disseminated tuberculosis.
So after discussing the radiology and other investigation, these were our revised possibilities. So we investigated in the line of these possibilities. For disseminated tuberculosis, we did a gastric aspirate for acid-fast bacilli and gene export, which was negative. So we did a bronchoscopy and sent the bronchoalveolar lavage, but that also cultures were sterile and gene export was negative. Our ANA and ANCA profile was negative. For cystic ILD, BAL cytopathology was done, but that was normal, and bone marrow aspirate was also normal. There was no evidence of any Langerhans cells. For sarcoidosis, the serum ACE levels were within the normal limit, but she did have hypercalciuria with increased urine calcium creatinine ratio, and her urine spot protein creatinine ratio was also increased. However, vitamin D levels, she had a severe deficiency. So we could not make any conclusive diagnosis based on this investigations. Thus, we opted to go for a tissue diagnosis. So lung biopsy was considered after discussing with the family. The options were VATS versus a mini thoracotomy versus cryobiopsy, and after discussion we decided to go for the transbronchial cryobiopsy. So the aspects of transbronchial cryobiopsy, I invite Dr. Tara to discuss.
So briefly, I'll just describe what this transbronchial cryobiopsy means. This is basically a middle path between a small bronchoscopic biopsy and a surgical lung biopsy. In a surgical lung biopsy, you get a very large piece of tissue. You get a nearly 4 centimeters tissue if you want to obtain it. In a bronchoscopic forceps, you get 2 mm size of tissue. By using a transbronchial cryobiopsy, you get a tissue with a bronchoscope which is nearly 8 times the size of a conventional forceps biopsy. So basically, this is done under general anesthesia. We do it under rigid bronchoscopy, and this is basically the procedure. You use a balloon. It's an occlusion balloon to prevent a bleed following a biopsy. And using a flexible bronchoscope, you use something called as a cryoprobe, which has got an intense freezing capacity. It can freeze like minus 90 degree in 2 to 3 seconds. And this is a cryoprobe which is inserted into a bronchial segment. By contacting the distal airway, we freeze a part of the tissue and we mechanically pull it out. So because it's a circumferential 360 degree freezing, you see here you get a circumferentially frozen large bit of lung tissue which is pulled out mechanically through a bronchoscopic segment, and then you can get multiple biopsies. So basically, we don't have much risk associated with this procedure. The two main risks are pneumothorax and bleeding. Bleeding is controlled by the use of an occlusion balloon. Pneumothorax is a real risk. So I think that is one thing which we have to look out following the procedure. And regarding the technique, it's performed under general anesthesia using a rigid bronchoscopy. So this is what we did, and I think it was an uncomplicated procedure, and she was, I think shifted back to the pediatric service.
So following the procedure was uneventful. The patient was extubated on table and transferred to the ward within 2 hours. However, 3 days later, there was a twist in the tale. 3 days after the biopsy went uneventful, the child threw an episode of another left focal seizure. So we investigated with a CSF analysis and neuroimaging. CSF analysis revealed 20 cells with a lymphocytic predominance, although the glucose and protein were normal. Cultures and gene expert and test for cryptococcus was also negative. Fundus examination revealed multiple hypopigmented lesions. For the neuroimaging, Dr. Rashmi will be discussing the neuroimaging aspects.
So we have contrast enhanced scans of brain. So here we can see that there is evidence of multiple T2 flare hyperintense foci, the same distributed in bilateral cerebral hemispheres as well as deep gray matter. And these did not show any restricted diffusion, and they show solid nodular enhancement on post-contrast images. And few blooming foci were also seen in the gradient images, likely due to calcification. And on the screening spine image, we could also see similar solid nodular enhancing lesions in the intramedullary location of the spine. And it was also seen involving the brainstem. So based on imaging, the differential diagnosis can be of that of granulomatous disease, either infective or inflammatory. So again, it narrows down to either tuberculosis or sarcoidosis.
So after this, our main possibilities that were remaining were, one was disseminated tuberculosis and one was sarcoidosis. It was the tissue biopsy and the histopathology which finally clinched the diagnosis. So discuss the pathology and invite.
Good afternoon. This was the transbronchial lung biopsy. We can appreciate multiple non-necrotizing epithelioid cell granulomas, tiny epithelioid cell granulomas. This is the normal lung parenchyma, and these are the non-necrotizing granulomas. This is the bronchial, so this is the peribronchial epithelioid cell granulomas. This is the interstitial epithelioid cell, tiny epithelioid cell granulomas, and this is perivascular epithelioid cell granulomas. So mostly multiple granulomas were seen, non-necrotizing type. This is interstitial epithelioid cell granulomas. So necrosis was not seen in any of the sections. This is peribronchial, vascular and interstitial granulomas. We did perform Langerin and CD1A immunostains to rule out LCH. Both were negative. This is the Estfag bacilli stain. This is also negative. So based on overall features of non-necrotizing granulomas in these all locations, we suggested the possibility of sarcoidosis.
So the final diagnosis that we made after the lung biopsy was of a generalized granulomatous disease, sarcoidosis. So the patient was diagnosed by the end of September and started on prednisolone at 1 mg per kg. However, within 2 months she developed complications. In October she had a recurrence of pneumothorax, which was treated at a local hospital with an ICD insertion and resolved within a week. And in November 2019, she again had a recurrence of pneumothorax. We can see a left-sided pneumothorax present in this chest X-ray. This time because there was recurrence of pneumothorax and continuous bubbling was present, a bronchopleural fistula was suspected. Chemical pleurodesis was not plausible, so pleurodesis was done by autologous blood patch installation. However, few days after pleurodesis by autologous blood patch, the patient again had a recurrence of pneumothorax, which was bilateral this time. To treat the pneumothorax, on the left side, wax was done with apical lung adhesiolysis and TAC pleurodesis was performed for the right pneumothorax, following which there was no further recurrence. So she was started on steroids, which were given for 1 year and gradually tapered off. At the same time, because of disease complications expected to be because of relapse, she was started on methotrexate and hydroxychloroquine. Methotrexate was given for 2 years and stopped in November 2021, and the patient continues to be on hydroxychloroquine. She's been following up in our pediatrics test clinic and is currently doing well. There is no fever, no cough, no breathlessness. She's gaining weight well, as we can see, and her pulmonary function tests have also shown significant improvement in the FEV1 and with the FEC. So for the discussion part, I invite Dr. Sheetal.
Good afternoon, everyone. Now I'll be discussing pediatric sarcoidosis in brief. So sarcoidosis is an uncommon multisystem disorder in children. It presents with diverse manifestation and has highly variable clinical course. The exact incidence is not known, but the reported incidence is between 0.22 to 1 per 1 lakh children per year, and the incidence increases with age. The hallmark of sarcoidosis is a non-gazing granuloma, as we have seen, and the diagnosis needs a high index of clinical suspicion and generally warrants a tissue biopsy. However, the diagnosis is often delayed due to non-specific symptoms in children. So the most commonly affected organs are lungs and intrathoracic lymph nodes, and neurosarcoidosis is extremely rare in children. The common symptoms include cough, dyspnea and chest tightness, whereas in case of neurosarcoidosis, it can present with headache, seizures, cranial neuropathy and space occupying lesions. Also, there are certain patients with high risk sarcoidosis. They have chronic progressive disease and they are generally treatment resistant with pulmonary, cardiac, neuro and multi-organ sarcoidosis. They carry poor prognosis and high risk of mortality. So there are certain typical and atypical features of sarcoidosis on HRCT, such as lymphadenopathy, which is typically hilar, mediastinal, bilateral, symmetric and well defined. Also we can see micro or macro nodules. The sarcoidosis typically has lymphangitic spread and therefore perilymphatic and peribronchovascular nodules can be seen. Fibrotic changes, bilateral perihilar opacities can also be seen. So in atypical features, if the lymphadenopathy is unilateral or isolated, or if there are GGOs or cysts, like in our cases, I have highlighted them in red. So these were some certain typical and atypical features of sarcoidosis in our patient. So what is the approach to diagnosis? There is no absolute diagnostic test for sarcoidosis. In children with over 5 years of age, teens and young adults, clinical presentation, imaging findings and laboratory parameters like hypercalcemia, hypercalciuria, increased urine calcium creatinine ratio, increased angiotensin converting enzyme, all this can point towards the diagnosis. If there is a typical bilateral hilar lymphadenopathy along with clinical features, then biopsy may not be needed. However, in cases of diagnostic dilemma, possibility of ILD, then mediastinal lymph node biopsy by endobronchial ultrasound TBNA and BAL CD4 CD8 ratio or lung biopsy can help to clinch the diagnosis. Also, it is very important to exclude tuberculosis, vaginal granulomatous and fungal infections, which are other granulomatous diseases. Also, there is an entity called as early onset sarcoidosis, which presents in children less than 5 years of age as uveitis, arthritis and skin rash, and for this genetic studies are needed for diagnosis. In acute sarcoidosis syndromes like Lofgren syndrome and Hereford syndrome, biopsy again may not be needed. So there are multiple causes of granulomatous lesions in children. They could be necrotizing or non-necrotizing. The necrotizing ones include Mycobacterium tuberculosis, very important, and vaginous granulomatosis. Whereas in non-necrotizing granulomatosis, sarcoidosis remains the foremost possibility. So in a country like ours where TB is highly endemic, whether it is a TB or it is not a TB is always a diagnostic dilemma. Therefore, there are certain indicators which can point towards sarcoidosis versus tuberculosis. Like history of tuberculosis may not be present in sarcoidosis. The constitutional symptoms are typically more common in tuberculosis. The cough is dry with no hemoptysis in sarcoidosis. Also, intrathoracic lymphadenopathy, as I have described, is symmetrical, bihilar, paratracheal, smooth, discrete, and solid. Whereas in tuberculosis, it is large, asymmetrical, conglomerate with necrotic nodes. The extrathoracic lymph node involvement is extremely rare in sarcoidosis, whereas it is commonly seen in tuberculosis. The lacrimal parotid and involvement may be seen in sarcoidosis, whereas pleural, peritoneal, and meningeal involvement is more common in tuberculosis. So again, these red highlights are well present in our case, and we can see that there is significant overlap. Coming to radiology, again bilateral hilar lymphadenopathy is typical of sarcoidosis, whereas in tuberculosis consolidation, cavity or miliary pattern can be seen. HRCT I have already described. The tuberculin test is typically negative in sarcoidosis. The AC levels will be elevated. There would be increased serum calcium or hypercalciuria. The CB-NAT would be negative in sarcoidosis. Biopsy reveals non-caseating compact granulomas, whereas in tuberculosis there would be caseating necrosis and ill-formed granulomas. The point to make is there is no response to ATT in sarcoidosis as was seen in our case, and the response to steroids is dramatic in such cases. So this is a retrospective review of 18 cases published from our unit, and we found that fever, uveitis and difficulty in breathing were the common symptoms, and 94% of the children had hilar lymphadenopathy. Coming to management, the natural history of sarcoidosis is spontaneous remission. However, systemic therapy is warranted in progressive symptomatic disease with persistent pulmonary infiltration and progressive decline of lung function. The treatment of choice is oral prednisolone. If there is relapse or non-response to therapy, then low-dose methotrexate, hydroxychloroquine, azathioprine, these are the disease-modifying agents can be added. People have also tried biologicals like infliximab. However, they are associated with significant side effects and the evidence is limited. So the options for tissue diagnosis for lung biopsy, they are surgical lung biopsy, transbronchial lung biopsy or endobronchial lung biopsy. And for mediastinal lymph node, we may perform a endobronchial ultrasound, transbronchial needle aspiration or CT guided transthoracic FNA if EBUS-TBN is not possible. So, sir has already described transbronchial cryobiopsy. It is done using cryoprobe under rigid flexible bronchoscope and larger tissues can be obtained. The complications are pneumothorax bleeding, which are less as compared to surgical biopsy. However, the yield of surgical biopsy would naturally be more. So, this is again our experience of cryobiopsy in children with diffuse lung disease, and we found that the procedure is quite safe. We could obtain tissue in most of the patients and diagnosis could be established in most of them, and there were hardly any complications. So my take home messages are: sarcoidosis is a multisystem granulomatous disease. It is a diagnosis of exclusion in most of the cases. However, clinico-radiographic evidence and histology are required for definitive diagnosis. Systemic therapy is not indicated in all, but in patients with progressive disease. The mainstay of therapy is steroids. Others include disease-modifying agents and biologicals. Lung biopsy may be performed by open thoracotomy or using a cryoprobe. And cryobiopsy yields larger tissue and has fewer complications and is safe. Thank you.
Thank you, Dr. Seetan. So this case is unusual in the many aspects. First is the sarcoidosis itself is uncommon in the pediatric age groups. And here is she has the sarcoidosis along with the recurrent pneumothorax. They are also uncommon, and neurotuberculosis very even the uncommon in the adults also, and very rarely in the pediatric age groups. And she didn't have the typical this hilar lymphadenopathy seen in the pediatric sarcoidosis. So that's why we need the tissue diagnosis, because the child had no typical features of sarcoidosis. And finally, we cleanse the diagnosis by the cryobiopsy. So now this case is open for any questions and comments. Any questions on online?
Yes. So, interesting case. I'm little interested in the neurological status. What reasons?
So after that, starting first child has the no recurrence of seizures and no other neurological manifestations.
Any imaging?
So we didn't perform that because,
So many reasons it's studied and been
because child is clinically well, so we didn't repeat the repeat imaging. Yes.
It's very difficult to say Sarkar is the one unless you have a picture of characteristic. Thing is, my question is, why if this patient develops so much still Sarkar? What is the reason behind it? Is there any reason that some will develop disseminated that I have noted?
So you are right, because there is no diagnostic gold standard for to diagnose this sarcoidosis. So we need the constitutional symptoms, clinical symptoms, along with the some lab evidence and the tissue biopsy. And at the, along with we also to route other diseases. Then only we can make the diagnosis of the sarcoidosis. Because there is no gold standard test, we can say this is sarcoidosis. Regarding the manifestations, because it's a very uncommon disease, so very difficult to say why some children have the mild manifestations. Even some children have the exponential remission without treatment, they are remission. And there's some children like this, they're very permanent course in a short time. Very difficult to explain why this is happening.
The recent HS is
Sorry.
recent HS is this child.
Also, we are not repeating the X-ray was normalized. We didn't repeat the CT scan.
This is comment regarding the clinical profile of these abdominal diseases. You mentioned that in a directly PHL introduction, the clinical profile you can avoid the biopsy. Unfortunately, all the data on the sample is not the best. So it's like they are saying that TB is uncommon, they say that you will go without the biopsy. But we have found this that a fair proportion of our, we have a series of 300 patients with pulmonary sarcoidosis in adults, and we found 13% had necrotizing granulomas and 10% had tuberculin positivity. So I think the clinical profile of TB versus sarcoidosis has a different nature in the TB endemic setting. This is one question which needs to be studied in the pediatric population.
So we have 2 minutes. So I want the final comments from the Kagra sir. Concluding comment, Kagra sir.
It's very difficult. Overlapping clinical symptoms and as you said, the clinical profile is slightly different as compared to this and in the ENL. And that's why we need to do a more effective investigation before we say that.
So in this case, this biopsy was very challenging because child has already pneumothorax, there are multiple system lesions, but because we have not shown the diagnosis, that's why we proceed for this biopsy. If there are no other comments, so we can conclude this case. Thank you all.
So good afternoon everyone. For the second case from the Department of Obs and Gynae Unit 3, we are presenting an interesting case of a postpartum lady with fever. And a clinical picture and a history really suggested that it is quite a clear case of chorioamnionitis, which it was not. And we had to, as her symptoms unfolded and we did investigate, we found that it was something different. And let's see, managed very successfully with support from the radiology, from pulmonology and from neurology divisions. And so let's see who is this empress of melody giving rise to fever in the postpartum period.
Good afternoon, everyone. I'll be presenting this clinical combined round for puerperal sepsis and the empress of all maladies. The case in discussion is 25-year-old pregnant gravida who conceived with IVF pregnancy for tubal factor, and it was her 6th attempt. She presented to us at 22 weeks period of gestation with preterm premature rupture of membranes. However, at the presentation, there was no suspicion of infection, like any complaints of pain, abdomen, fever, bleeding per vagina. Her antenatal history was quite unremarkable. However, there was a history of threatened abortion in first trimester. On presentation and examination, her general condition was good. There was no pyloric teres, cyanosis, clubbing. Vitals were stable. There was no abnormal significant finding on systemic examination. The per abdomen, the uterus corresponds to 20-week size. It was relaxed, non-tense and non-tender. There was no foul smelling discharge, but we could see a frank leak coming through the os. So we counseled this patient regarding the pre-viable rupture of membranes, and the option of continuation and termination of pregnancy was given, but the patient insisted on continuing the pregnancy. So we started her on antibiotics as per the standard protocol, and we observed her for chorionitis based on the clinical features and lab parameters. At 24 weeks period of gestation, we gave her injection dexamethasone for fetal lung maturity. However, there were complaints of on and off headache and vomiting, for which medicine consultation was sought, and migraine was suspected and managed conservatively. In her investigation, we could see that the total leukocyte count was in the normal limits, within normal limits throughout her antenatal periods. The CRP was on higher side, but it was constant. On high vaginal swab, early there were commensals, then it was more than 3 types of GNB colonies. Finally, on the 4th of March, the high vaginal swab grew Enterobacter cloacae, which was sensitive to piperacillin and tazobactam. So we started her on piptaz on day 22 of admission. After 2 days, at 25 weeks period of gestation, she went into spontaneous labor and delivered vaginally a female baby of 720 grams, followed by manual removal of placenta under GA. In her postnatal period, she developed high-grade unremitting fever with chills, which was responding to injection PCM. However, there were no localizing signs of infection. On examination, the breast was soft, the chest had nothing abnormal, PA was soft, uterus was non-tender, lochia was healthy, and there was no signs of DVT. On further investigation, we could find that she was mildly anemic. The TLC was normal with no leukocytosis, and the procal was on higher side, and CRP was a little bit on the higher side. So we further investigated her as to rule out any chorionitis. So we did her blood culture, urine culture, high vaginal swab, and placental membrane culture, but it came to be sterile. And we thought of ruling out some viral infection as well. So we did influenza, COVID, RT-PCR, which was negative, and malaria and dengue also came out to be negative. We did her ultrasound, but the uterine cavity was empty. There was no products of conception, and there was no features of endometritis as well. So a provisional diagnosis, she was not fitting into chorionitis, puerperal sepsis, or viral infection. So to rule out any unusual cause of fever, we did an HRCT for this patient, which was suggestive of multiple central lobar nodules in bilateral lungs, predominantly on the upper lobe. In view of CT findings, tachypnea, respiratory alkalosis, and deteriorating general condition of this patient, pulmonary consultation was sent, and she was shifted to pulmonary ICU in view of atypical pneumonia on postnatal day 8. In the same night, she developed altered sensorium, right upper limb and lower limb weakness, and left eye ptosis. So neurologic consultation was done, and CE, MRI, brain and lumbar puncture was advised. And on MRI, this was suggestive of TBM with tubercular infarct, and on this has same picture on the lumbar puncture as well. So finally, we made the diagnosis of tubercular meningitis. Now I would like to call a radiological colleague of mine, Dr. Rashmi, to discuss the images.
So I'll be discussing the radiological aspect of this patient. So we have contrast enhanced scans of abdomen and chest for this patient, wherein we can see a patchy area of consolidation in the apico-posterior segment of the left upper lobe. There was no other positive finding. Mediastinum and abdomen were normal. So these are the contrast enhanced imaging of brain. So here we can see that there is evidence of multifocal patchy T2 flare hyperintensity involving the inferior medial aspect of the left frontal lobe and mesial region of the left temporal lobe. We can also see hyperintensities in the external capsule and genu of the corpus callosum and in the left cerebellar hemisphere. These appeared hypointense on T1. And all of these lesions showed true diffusion restriction, and a blooming focus was seen involving the mesial region of the left temporal lobe, likely a microbleed. On contrast, post-contrast images, there is evidence of leptomeningeal enhancement along bilateral sylvian fissure and along the perimesencephalic cisternal spaces. We can also see there is enhancement of bilateral third cranial nerve and enhancement along the intracranial aspect of the bilateral optic nerve. So, on imaging, features are consistent with meningoencephalitis, likely due to infective cause, that is tuberculosis.
And I would like to call neurology colleague of mine to discuss further management.
So we were informed about the case on the 14th. So in the first contact with the patient, the history was taken from the husband, where the history of high-grade fever was given, which was associated with moderate intensity holocranial headache. This was also associated with projectile vomiting since the same duration. And 1 day prior to which we were informed, that is on the 13th, the patient had developed paucity of movements in the right upper limb and lower limb, associated with drooping of left eyelid and complete restriction of ocular movements in the left eye, and also altered sensorium since the same duration. So in the first contact, the GCS at presentation was M6 drowsy. There was pallor on examination. In the cranial nerve examination, there was complete ptosis in the left eye with ophthalmoplegia. There was involvement of the 3rd, 4th, 6th cranial nerves, and left pupil was sluggishly reacting. There was also right-sided Human type 7th cranial nerve involvement. On fundus examination, the patient had bilateral grade 1 papilledema. She also had meningeal signs which were positive. On motor system examination, the tone was reduced in the right upper limb and the lower limb with complete plagia in the same side. All the reflexes were exaggerated and the right-sided plantar was upward. So this is the image of the patient which was taken subsequently in our ward, which shows that there is a complete ptosis in the left eye and also there is right-sided facial palsy. So summarizing from the history and examination, so she was a 26 years old female and she was postpartum day 7 when she came to us and presented with clinical features suggestive of a meningitis-like illness, which was followed by a sudden onset right hemiplegia and associated with complete ophthalmoplegia in the left eye. So likely due to a superimposed vascular event. So from the clinical point of view, the differential diagnosis before the imaging was seen was high chance was that of an infective cause, which was in the first tier, either tubercular or fungal. Second was a vascular cause since she was postpartum. So sequelae of CVT with a venous infarct or hemorrhage. Also a subarachnoid hemorrhage due to RCVS or other causes of stroke in her. And last cause was a structural event. So the relevant investigations which were done in her, in the blood investigation, her hemoglobin was on the lower side, ESR was 42. CSF done showed 160 cells, 70 majority were lymphocytes. Protein was on the higher side, 361. Sugar was on the lower side, 27.2 with a corresponding RBS of 113. In her infective workup, all were negative except the CSF gene expert, which had come positive and which was sensitive to rifampicin. So the initial CT finding, which was on 13th, the patient was having altered sensorium, so there are a lot of motion artifacts. What can be clearly discerned is there is a hyperdensity which is seen in the region of the left sylvian fissure. And this was the subsequent CT which was done with us on the 17th. This is an NCCT head axial view. This is showing that she has developed infarct in the left gangliocapsular region and also the thalamus. And subsequently on the 18th, we see the initial hyperdensity which was seen had resolved, but there was an hypodensity involving the left temporal lobe. This is a susceptibility weighted imaging MRI, which is showing, which was also described by our colleague, that this is showing a blooming in the adjacent perisylvian area on the left side. This is the MRI which was repeated with us. This is the axial T2 MRI, which is showing again a hyperintensity around the left sylvian area. On the post contrast, we see there are basal exudates. There are also leptomeningeal enhancements, and the flare imaging which are confirming our findings. These are the ADC DWI maps. So this is clearly showing that there are vasculatic infarcts in the anterior as well as the posterior circulation region, which can confirm our clinical findings in the patient. And on the MRI TOF imaging, we are seeing that there is attenuation of bilateral MCA more in the left than the right, M1, M2 division, as well as the left A1 ACA. So treatment was started on her immediately. So we 4-drug ATT was started, that is HRZ. Initially she was started on levofloxacin in pulmonary medicine side, but we subsequently changed it to streptomycin. She was also continued on weight-based injectable steroids. So she was given a pulse MPS initially for 5 days, 5 days, sorry, which was followed by injectable steroid for 2 weeks. And currently she is on oral tapering dose of dexamethasone. Ecosprin 75 mg was also started, and she was continued on Rilestio feed due to the dip in sensorium which she had, and subsequent physiotherapy was continued. So she was discharged after 2 weeks stay with us, and her sensorium had improved to good M6, and her fever had subsided, and she was discharged with MRS 4 status.
Coming to the baby outcome, the baby had respiratory distress syndrome, so the surfactant was given to baby. Baby developed grade 2 intraventricular hemorrhage. She had 2 episodes of clinical sepsis and requiring antibiotics. She was ventilated for 10 days, followed by non-invasive ventilation for a month, and currently intubated for 12 days with high ventilator settings attributed to severe bronchopulmonary dysplasia and on full feeds. Baby never was tested for tuberculosis. I would like to call Dr. Dipali for discussion.
Good afternoon. So initially we were in dilemma because of the prolonged leaking PV. We were thinking on the line of the chorioamnitis, and we were thinking that this fever is because of the chorioamnitis, but we were not getting any clinical signs or any laboratory feature which could suggest, or any radiological findings which could suggest our findings. And also fever was not responding to the antibiotic until it was she showed meningeal signs, and we found on HRCT that she has some findings in the lungs. So it was a very good teamwork, so we could timely diagnose this unusual diagnosis, and we could save our patient from this fatal illness. So it was a really good teamwork. So 1/4 of the global population is estimated to have tubercular infection, and out of these 1/3 are in females. And currently the tuberculosis is the second most common cause of the death for a single infection agent worldwide after the emergence of the COVID-19. Before COVID-19, it was the first agent. Now each year over 2 lakh cases of the tubercular infection occurs in the pregnant women, and it has been told that apart from obstetric causes, non-obstetric causes, the infectious diseases are now responsible for 28% of the maternal mortality worldwide. Most common is the pulmonary tuberculosis. The extrapulmonary tuberculosis take place in the 15% of the general population, but the percentage of extrapulmonary tuberculosis is higher in the pregnancy. Exact percentage are not known,
and the tuberculous lymphadenitis being the commonest extrapulmonary tuberculosis, and the extrapulmonary tuberculosis affecting the CNS occurs in 5 to 10% cases. The effects of tuberculosis on pregnancy depends on the various factors. If the disease is severe, the site of infection is extrapulmonary, is there an associated HIV co-infection, or there is advanced gestation, or late treatment initiation, or poor compliance. These are the leading factor for the adverse outcome. The effects of tuberculosis on pregnancies are increased chances of abortion up to 9 times. There are increased chances of anemia, fetal growth restriction, 2 times increased chances of preterm birth, preeclampsia, cesarean delivery. There are 6-fold increased chances in the perinatal death. The infection of the tuberculosis can occur to the fetus during the pregnancy or even after the pregnancy in the postpartum period. And also there are increased chances of maternal mortality as well as the morbidity because of the tuberculosis in the pregnancy. So there was a study done by Dr. Vikas and Dr. J.B. Sharma of AIIMS in 2019. It was published in Indian Journal of Tuberculosis. They saw the obstetrical and the perinatal outcome in the pregnant women with extrapulmonary tuberculosis. They took out the retrospective data of past 10 years and they took out total 30 cases of extrapulmonary tuberculosis. Out of these 30 cases, 22 were already diagnosed and then later on they got pregnant, but 8 cases were diagnosed during the pregnancy only. Out of these 30 cases, 15 cases maximum were of genital tuberculosis, and they found out that there was significantly increased incidence of oligohydramnios, preterm labor, and premature rupture of the membrane. Out of 30, 1 maternal mortality and 1 stillbirth occurred. The effect of pregnancy on tuberculosis, there are no conclusive evidence, but it has been said that probably the pregnancy worsens the tuberculosis, and all pregnant women are at increased risk for developing tuberculosis disease during pregnancy and in 6 months postpartum. It could be partly because of there could be delay in the diagnosis during pregnancy. Why there are flare-ups seen in the pregnancy? Because pregnancy is the period of systemic immune modulation with a complex balance of immune suppression, prevents the rejection of the fetus and maintenance of the ability to fight off infection. And during pregnancy, there is a switching from the cell-mediated immunity, that is Th1 immunity, to the humoral immunity. And during the postpartum, there is a rapid reversal of Th2 to Th1. So, during pregnancy, because of the lowering of the Th immunity, the patients are more prone for the infections like tuberculosis. But they don't show their signs. They show signs when their pro-inflammatory phase, that is Th1 phase, it improves during the postpartum period. Also, poor outcomes are because of the delay in the diagnosis during pregnancy. The delay during the diagnosis during pregnancy are because there are masking of the TB symptoms by pregnancy-related symptoms like shortness of breath, fatigue, nausea, vomiting, malaise, and pain abdomen. These could be attributed to the pregnancy also. And there is reluctance to perform certain diagnostics, especially the X-ray chest, by the healthcare worker because of their fear for the X-ray exposure to the fetus. And there are also increased cases of extrapulmonary tuberculosis in the pregnancy, which usually their presentation is so valid that it is very difficult to clinch the diagnosis because there is a vast variety of their presentation. There is one, there was a retrospective review done by Kothari et al. In 2006, and they found out that the median duration of symptoms prior to the presentation was 31 days and being longer in the women with the extrapulmonary tuberculosis. The longest was 10 years. The median interval from the presentation of the symptom to the diagnosis was 32 days. And the commonest reason for the delay in the diagnosis was late presentation,
followed by the non-specific symptoms. There are varied presentation of extrapulmonary tuberculosis in pregnancy. There is one case report which showed patient presented after the delivery with a lower back pain and with a pain of sciatica, which on later on while doing radiological examination, it was found out to be the psoas abscess, which was primary psoas abscess, which was jailed later on. In another case, they found out that after the 1 week of the cesarean section, the patient presented with cough, fever, and pain abdomen. They found out that there was fluid inside the abdominal cavity. They thought of that it is because of the secondary to the septic pneumonia. But later on, when they operated the patient, they found out that it was ovarian tuberculosis only. In another case report, patient presented after the delivery. She presented with the pain abdomen and fever, and it was mimicking like patient has malignancy, but it was later found out that patient had peritoneal tuberculosis. In another case, patient presented the casualty with fever, breathlessness, and patient was attached to the casualty only. And on further investigation, it was found to be patient has disseminated tuberculosis. Later on, this patient expired. In another case report, it was seen after 4 months of delivery, patient presented with painless abdominal distension and weight loss, which mimicked the carcinomatosis. But on further investigation, it was found to be the peritoneal tuberculosis. In some other cases, like CNS tuberculosis, patient didn't present with fever and headache. They presented with psychosis, and during whole of the antenatal period, patient complained of patient was treated for psychosis, and very late patient presented with meningeal signs, and when she was diagnosed to have tuberculosis, at that time patient expired. And some patients of CNS tuberculosis very rarely would present with blindness also because of the tuberculoma in the optic chiasma and optic nerve. So, presentation of tuberculosis during pregnancy because of the extrapulmonary tuberculosis, it could be very much varied. So, to trace the diagnosis is really very a challenging job. In our case, it was a neurological or CNS tuberculosis. The CNS tuberculosis clinically it presents in 3 forms: diffuse form or tubercular meningitis. It is the most common cause in 70 to 80% cases, followed by the focal form or tuberculoma and the spinal erythritis or TB radiculomyelitis. Initially, there is a primary lung infection which leads to the hematogenous dissemination. Later on, when the conditions are favorable, leads to the seeding of the meninges and the ependymal tubercles. Later on, there is a rupture of these tubercles into the subarachnoid space, and it leads to the cytokine-mediated inflammatory response and meningitis. So, clinical presentation, the duration of the symptom before presentation, it ranges from several days to several months in extrapulmonary tuberculosis presented at tubercular meningitis. Fever, headache, stiff leg, these are also present, but in early stages, these could be absent also. There are seen multiple cranial nerve palsy, especially the cranial nerve 3, 4, and 7, as occurred in our case also. And there are also seen hemiparesis, paraparesis, and seizures. The pregnant patient and postpartum patient, they have the hypercoagulability. Because of these, there are increased chances of arterial strokes or central venous sinus thrombosis, which lead to the increased incidence of TB meningitis associated neurological deficit, which also occurred in our case. So, the diagnosis of tuberculosis mainly depends upon the CSF findings, the radiological features, and the histopathological features. In CSF features, there are mononuclear pyrrhocytosis, low sugar values, high protein content, and there is definitely Mycobacterium tuberculosis either on the culture or the staining, and molecular analysis is the confirmatory. In radiological features, there are basilar, leptomeningeal enhancement and exudates, hydrocephalus, cellular infarcts and tuberculosis. Because of the thick exudation, there are hydrocephalus. And on histopathological, there are granulomas which are typical of tuberculosis. In an article published by Infectious Disease Society of America in 2022, Patrick et al. They did a pregnancy-related tuberculous meningitis and immune reconstitution inflammatory syndrome, a case study and systemic review. They did a meningitis clinical trial in Uganda from 2018 to 2022, and they identified 8 cases of the pregnancy-related tuberculous meningitis. Later on, they did the systemic review of these meningitis during pregnancy, and they found out 40 more cases. Of all these 40 cases were non-HIV positive. And out of these 48 cases, 50% were diagnosed during postpartum and 50% were diagnosed during the antenatal period. And those diagnosed during antenatal period, 38% had their worsening of the symptom or disease relapsed in the postpartum period. The diagnosis was missed or delayed in 33%, and importantly, the maternal mortality was quite high. It was 23%. And fetal and neonatal mortality was also quite high, 30%. And in 30% cases, they had residual neurological deficit, which is quite important. So WHO guidelines for pregnancy with tuberculosis, pregnant women living in the areas of high TB burden like in India should be screened for TB disease at every contact with a health worker. The screening should be 4 symptom screening method, that is cough, night sweats, fever and weight loss. The screening for weight loss should not just consider the absolute weight loss, but it should also check for the failure to adequately weight gain during the pregnancy. The chest radiography can be used to screen the pregnant woman for tuberculosis disease with the prevention of X-ray exposure to the fetus. The benefits of accurate TB diagnosis outweigh the risk of the radiation exposure. All pregnant women with a TB should be screened for HIV infection if their HIV status is unknown, and AIIMS prophylaxis for immune compromised women is mandatory. Now I would like to invite Professor Vijay Hadda for the discussion of the treatment of such tuberculosis meningitis patients.
Good afternoon, everyone. So, I was contacted, I think day 3 or 4 after this postpartum. I got a call on the phone that there is a patient who is running high-grade fever and we are unable to find any cause. And after some hours, they told that this patient is deteriorating. Can you take this patient in ICU? This patient is too sick. Then we take the patient to our side, and initial impression which I was carrying was it may be some hospital-acquired infection. That the patient is so sick, and I directed my team that let us investigate him for hospital-acquired infection. But along with that, she was carrying a CT scan which was done a few days back, which was showing some lung lesion. Although still I hope it may be some bacterial infection because there is a nodule, and based only on single finding, it is very difficult to make any diagnosis. But when we examine the patient closely, then we observe she had some neurological feature also. That raised our suspicion that we are not dealing some hospital acquired infection, there is something else. And subsequently we did CSF, and CSF showed some finding which was suggestive of chronic meningitis. Some lymphocytes were there, and imaging was showing some temporal lobe area hyper intensity. We thought it's still some kind of virus. So in fact we gave antiviral also in ward. But when we got this complete evaluation of CSF, that clears the diagnosis. The gene expert was positive, and subsequently we discussed the MR in radiology department also. Then they suggested that because of this thick exudates in the basal area, which are highly against the viral infection, so then we were a little bit sure that they are dealing with tuberculosis. And once the diagnosis is made, treatment is as we are treating a normal patient. There is no separate guidelines to treat a patient who is pregnant versus non-pregnant. So all this standard therapy which is given to a normal adult are same apply to pregnancy also. That's all. That's all. But I want to say. So I don't think there is anything to add on.
So our take-home message is pregnancy, postpartum are associated with flare-ups and delayed diagnosis of TB. There should be high index of suspicion to diagnose this condition. The risk of untreated active tuberculosis disease on the pregnant woman and on the fetus is greater than the risk of treatment. Although all the drugs which are used in treatment of tuberculosis are safe during pregnancy, the timely diagnosis and management improves the prognosis significantly. So this is the picture of a lady who was a novelist in UK. She is Charlotte Brand. She succumbed to death because of the tuberculous meningitis during pregnancy. So I would like to invite Professor Varsa Dadwan for the concluding remarks.
So like already presented, we thought of chorioamnionitis first because she had prolonged leaking and an MRP, but then she didn't respond. Cultures came back sterile. We thought we should investigate further, maybe some unusual cause of fever. The investigation bloods were normal, so we went ahead with the CT. Then we thought maybe it is a chest infection which is manifesting. But till now, the patient never had any meningeal signs. The only thing was history of headache on and off and vomiting, which was also there in the antenatal period. But in the absence of meningeal signs, we did not take that seriously. Maybe that was a pointer, but very subtle signs. But anyway, if you look at the literature, the delay from symptom onset to diagnosis is pretty long. But here, at least with the team effort, we could cling to the diagnosis within 8 days, give her management, and she went home much improved, and she's doing quite well. And I think tuberculosis is the empress of all diseases. We should always keep her in mind and never forget her. Thank you. Any comments from the neurology team, Dr. Sharma or anyone? Mike.
Actually, we came into the picture once this patient was in pulmonary ICU, and before we saw the patient, we actually saw the image. So I became uncomfortable with the kind of image because that throws 10 diagnoses. You see a non-contrast CT scan with a bleed in the sylvian fissure in a patient who suddenly become altered after headache. It could be a subarachnoid hemorrhage, it could be a cerebral venous thrombosis in a postpartum patient. It was only when we went to the pulmonary ICU and saw the patient in person and then we discussed the history with the husband that we were very clear that this patient had history of some constitutional symptoms, headache, vomiting, which has been simmering for at least a week or so. And with that accompanied, if you have meningeal signs and if you have focal neurological deficits, then there are very little differential diagnosis. And this case probably tells us that uncommon presentation of a common disease is more common than common presentation of an uncommon disease. You know, the old clinical learning that we always see. And once the CSF was done, I think it was all sorted. But also important thing was that before even we did the fancy investigations like MRI, like CSF, I think on clinical suspicion, ADT was started, and that really made the difference because a delay in treatment by even a day or 2 days in a patient who's already developed altered sensorium, in a patient who's already developed focal neurological deficits can lead to a downhill spiral more, so the treatment is not stuck on time and if investigation reports are made. Thank you.
Dr. Sharma, if you have a vast experience of managing patients with tuberculosis.
Congratulations for the excellent management and so, I mean, as said already, basically, when we slowly suspect TB whenever they think it and rightly said, common disease, common medicine, especially like this patient had those medical scares, she had done but he said that we see other way problems, like we see patients of many patients that we see only turn out to be masquerading as like ovarian cancer. But we also have other way of also. Patient of ovarian cancer being given baby, that is a bigger scale. You can doubt better, you know, taking the diagnosis of tuberculosis. But I think this case very clearly highlights the role of multidisciplinary microbiology that we would have timely diagnosis for patients. But like such cases, and within that glucose and component absolutely false. We are seeing almost equal number of PV cases for the same. We are seeing more complicated cases. And don't think it is a reason poor patient. We have seen it in Mr. Hospital sometimes. And it's not same as MDRT and all of you patients, please be aware. Every year 8 to 10 PGs from AIIMS, 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 especially from medicine, they get TB because you are seeing open patient of TB and our one of our residents in AIIMS, see for MDR-TB because whatever the source of infection, if you source TBS cases MDR-TB, then you get MDR. So please take all precautions while dealing with these patients and you don't need to take fast from quickly for lunch and all, and that this is the immunity. So take care of your own health. Every year 10, minimum 10 to 15 PGs catch TB or out of the 20 to 30% MDR. So that is the, it's still a very important. This is not less important. And unfortunately, because of COVID, it has whatever gain we made in last 10 years, we have gone back to 1915. So whatever gain in TB was there, so we had to have to talk of concrete disease like 2030. Now probably we have to take a course on it 2040. Because all admin that and all sources funds care went to accept COVID and distributed to HIV, but TB was very clear. So thank you very much. You Dr.
Dr. Smita, would you like to say?
Why suspicion is required, and in terms of neurological manifestations, definitely a contrast MR is required. So that was the point of diagnosis was made and further
any particular MRI, scheduling, etc. can include diagnosis?
post-contrast MR is required because we pick up that abdominal has multiple
And
that becomes a very
rare finding, but we did see it.
anyone from nuclear medicine department, PET CT compared to Rakesh Kumar can detect actually TB activity in these patients, like in some of our patients with ecovariant masses. And especially when we have treated the patient and still TO mass is persistent. So we are in a dilemma because we can't take biopsy easily from TO mass. We are in a dilemma whether it is just a persistent like disease or just a fibrotic disease like in lymph node. So then we had treated like PET CT in these patients, and if this was increased TB activity, it will tumor obtained. So that showed with the active disease, and then we extended the treatment. But if it was just fibrotic lesion without the TB activity, so PET CT may have a role. I mean, any of them, they are not here. So similarly, like Ravi Mittal did study in skeletal TB. So they did study after 6 months, 9 months, 12 months, 15 months. So they could find these abscesses and some disease got cured in 6 months, then 9 months, 12 months. Some lesion was still persistent after 1.5 years also. So I mean, PET CT may help in finding the endpoint for these patients. So I think such study maybe in CNS TB you can do. I think 1.5 years you can do that. You know the exact like pulmonary TB 6 months, and that also is arbitrary. Vijay can tell better than me. We have just made it arbitrary 6 months. I mean, why not 5.5 months, why not 6.5 months? So arbitrarily we have found it. So maybe if we find some, and luckily in pulmonary TB you can get AFP microscopy also, but in extra pulmonary that is difficult. So I think still there is a gray area. I am not solved.
Thank you, everyone.
ANCRP actively screening for tuberculosis. As developer recommended that each patient was coming to ANC clinic, they should be screened with 5 symptoms.
We don't yet. In USA, etc., they are looking for latent TB also. But if we do latent TB, maybe this or 60 or 70% of us will have latent TB. So then we will be should be trained or not. So usually in India, they are good. We got latent TB, but at the same time, having any suspicion of that, then we must. And I was hesitant to do a simple test because the liquid, I mean, there is so much little radiation, there is no harm to the fetus. That should be avoided. Do the testing wherever possible. And I see that very simple are the very and mileage and weight loss, we stay very pregnant of 20% testing. I guess and simply like to many times the all approach to gain our place from alumni medicine and all. Like there were 26 cases of MDR treating in regular area. No doctor asked the patient about menstruation, the patient was accident and the main doctors. And then they fell pregnant and by the time they were nobody bothered. There were 26 to 28 cases MDR drugs, like I think more than just content. But what is that supposed to be our mind? But then so please be only that patient can be pregnant also. Capillary than use contraceptives, especially for women.
On the other hand, tuberculosis as a presenting symptom, amenorrhea is usually also.
That is about that. Many patients may amenorrhea in psychiatric patients also, severe disease patients also. That is the high collective. But I will always please suspect that you see recently we have 12, 13-year-old girl being operated as 26 is pregnant was this. So we had a patient with all of neurology. I got a call from my SR. She said, was admitted in neurology department of AIIMS. She was 26 weeks pregnant. And no, I mean, everyone mistake was married. Nobody thought of pregnancy. And she was having fits. So she was being pregnant on IV tests. I said, these things may be eclampsia. And then actually, females were bad inside, she was pregnant. So even unmarried girls can have pregnancy. So that is important for our. So these things important. Sorry.